Okay, good afternoon, professors, doctors. I'm Dr. Paek from Janghyun University, Seoul, Korea. As a prosthodontist, I'll be covering optimal prosthetic strategies for single implant. Before I start, I'd like to express my sincere gratitude for your kind invitation and all the support from the organizing committee. Thank you for having me. This is the overview of my presentation. The critical issue is the prosthetic requirement for immediate loading prosthesis. I'll cover some literatures, do a literature review, and I'll be talking about prosthetic consideration in immediate loading of the implant. This is a well-written article, classic old article published by Carl Misch and Homlei Wang, the rationale for the application of immediate load in implant dentistry. In this article, it is reporting that 75% of all failures occurred in patients with bruxism. Also, the angle of the load to the implant body should be along the long axis, especially when the crown height is greater than normal. Here's another recent article published by Shetty last year. Here, it also states that the provisional restoration should not be an occlusion, especially when the patient has parafunctional habits. In this article, these prosthodontic modifications should be considered to protect our newly placed fixtures. Number one is to reduce the cusp inclination, and number two is to reduce the size of occlusal table. And these two recommendations are in accordance with the article published by Monberg in 2003. How much do we need to reduce the width of occlusal table? This article says we need to narrow the occlusal table by 30% to reduce the lateral forces. Back to Shetty's article, providing wide-centric occlusal freedom by 1.5 millimeter horizontal fossa will reduce the heavy occlusal forces, especially when there is an immediate side shift of the mandible. Same illustration here. In this picture, you can see the occlusal line angle and grooves reshaped to contain a 1.5 millimeter horizontal fossa. Next recommendation from the literature is the reduction in number of occlusal contacts. The primary occlusal contact should be in the diameter range of the fixture, and the secondary occlusal contact should be within 1 millimeter of the periphery of the fixture. Also, as we all know, there should be no cantilever extensions. I mean, for single implant, of course, there will be no cantilevers, but it is also very important not to have wide occlusal platform because it may act as cantilever in buccolingual direction. So tilted implants and buccally cantilevered restorations can create non-axial occlusal loading due to the position of the crown in relation to the fixture. That's why we have to reduce the size of occlusal table. And lastly, in this article, there's an issue with the diet of the patient. We already mentioned about the diet. So during the first week of the healing, the patient should be in a soft diet. Many articles are reporting the importance of the soft diet. See, we Koreans do eat a lot of hard food and tough foods, and those are contraindicated. But in the article, the real wording was the pasta and fish are acceptable. So now let's go back to the occlusion and function. Should we provide occlusal context or not? This report by Dr. Goh says there is no significant difference between functional loading and non-functional loading. The success rate is about the same, which is about 96%. And because this article was a review article, many authors were saying differently regarding occlusal contact. Some authors preferred 1 or 2 millimeters short of occlusal contact, and some authors recommended minimum amount of disclusion by 40 microns. So to summarize this article, we should have narrow occlusal platform, and occlusal contact should be inside the implant diameter, and there should be flat cusps, and the patient should modify their diets. Last but not least, there is also recommendation for lateral guidance, And for posterior contact, there should be no lateral interferences. And for anterior tooth, there should not be one tooth taking all the forces. Instead of providing canine guidance, we have to adjust our occlusion to provide good function occlusal scheme. And we have to distribute protrusive forces evenly to all of the anterior teeth. Good and very tight interproximal contact should be obtained to eliminate the micro movement. If we do have a good tight interproximal contact, that will minimize the rotating micro movement of the provisional restoration. And there was a disagreement on when and how to provide occlusal contact. But as doctors already told us, to be on a safe side, it is recommended to provide very light sensory contacts only. So how can we succeed in immediate loading before complete osseointegration? Our mouth is harsh environment with heavy occlusal forces, and this heavy occlusal force will cause micromovement. And as we know from the literature, micromotion that is greater than 50 micron will lead to the failure of osseointegration. This is why we have to control the forces so that the movement will not exceed 50 microns. To control forces, I have to emphasize again to reduce the cusp inclination and the size of occlusal table. However, in eye fixation cases, even though we achieve more than 40 centimeters, we have to limit ourselves not to load the implant. We have to wait 3 months, we have to wait 4 months, we have to wait 5 months until it achieves biologic C fixation. The most important thing we have to consider in eye fixation cases is that the crown to implant ratio is unfavorable. If you can see, in a C fixation cases, we do have a nice crown to implant ratio. In M fixation cases, we still do have okay crown to implant ratio. However, as you can see, in eye fixation cases, we inevitably have very unfavorable crown to implant ratio. As you can see from here, we do have external lever arm, and non-axial loading increases as the crown height increases. It creates bending forces which will affect our crestal bone. Therefore, in eye fixation cases, we have to provide only anterior aesthetics, no lateral forces, and it has to be totally out of occlusion. Let me show you the clinical case. The anterior bridge work from tooth number 11 to tooth number 13 was failing, and tooth number 21 was also failing. So this is the sagittal view of tooth number 21. And this is the actual frontal photograph of the patient. And the treatment plan was thoroughly discussed with the patient, and we decided to redo the bridge work for right anterior teeth and one single implant for left central incisor. At the day of extraction, we immediately placed our implants and immediately loaded the implant. Look at the nice cervical contour of the provisional crown. And this is day 1 after the surgery and loading. Because we immediately placed our provisional crown at the day of surgery, we could maintain papilla, and the patient was very happy with the aesthetics because he didn't get any flippers with wires. So after the healing of the surgery site, I did a bit of soft tissue contouring with quartz diamond bar, football-shaped bar, to make my pontic base contour more favorable. We added some more acrylic to make the symmetrical contours of the anterior teeth. Nicely scalloped contour of the soft tissue were achieved. And this is the occlusal view of the contoured soft tissue. And this contoured soft tissue was transferred by using intraoral scanner, and the definitive prosthesis was delivered to the patient. And the left is preoperative photo, and the right is postoperative photo of the patient. Not only aesthetics, but there is also occlusal consideration in this type of eye fixation cases. As I told you earlier, we have to eliminate the occlusal contact in anterior eye fixation cases. Moreover, we have to make anterior guidance very shallow. How do we make shallow anterior guidance? That is either by decreasing the vertical overlap or by increasing the horizontal overlap. We can do it by making anterior teeth a little bit short, or we can do it by making anterior teeth a little bit out to the labial. So now let me finish my presentation. We have to protect our implants from biomechanical overloading, especially in single standing implant. When doing immediate loading, controlling the occlusion is at its foremost importance. My recommendation today is just a generalized recommendation. The specific occlusal considerations should be modified appropriately in presence of individual clinical determinants. Thank you for your kind attention, and now I'd like to toss to Professor Richard Leesungbok for optimal prosthetic strategies for multiple implants. Thank you.
Thank you, Dr. Paek. A nice presentation. And I will focus on the multiple implant placement and also long span prosthesis. So clinical issues. What is top-down and restoration-driven treatment planning? And will you do cross-arch splinting for a full-arch prosthetic solution in the treatment of extensively and a fully edentulous jaw? Or will you take the form of the segmented bridge? And can the number of implants be reduced by cross-arch splinting for a full-arch prosthetic solution in the treatment of extensive fully edentulous jaw? So there's many learning objectives. So it takes time. I skip this slide. Edentulism. Edentulism fulfills the WHO definition of a physical impairment similar to disorder. Edentulism is also disability because it limits the ability of the individual to perform two of the most essential tasks of life, eating and speaking. That some individuals avoid eating in the company of others because of problems with chewing. This in itself fulfills the WHO definition of handicap. Right side, so many removable dentures, failed dentures. Don't use. Yeah.
Is that just from one patient?
No.
The whole family.
Okay. General eating habits of Korean seniors, even in this old age, elderly people chewing directly and biting and pulling like this. The popular food that Korean elderly enjoy eating like this. Kimchi 깍두기 and soju and the sticky food, everything. So, to the elderly people, can they chew food right away or not? That's the biggest issue in Korea. Most of the Korean people, hurry up, doctor, hurry up. I hope to have chew after implant placement right away, today, like that. We have to do that for the elderly people. The 88 years old man, the upper complete denture several times as a repaired feature, and lower anterior severe mobility and no posterior teeth. So I placed it's a IS2 active 4.5 and an 11.5 millimeter length on the after extraction immediately placed on the canine area like this, and check the insertion torque of 14 Newton centimeters and the C3 M2 I1 fixation D3 to 1. So immediate implant placement, you check the CMI primary stability. So I placed temporary restoration like this, and then right away, patient can chew everything with this temporary restoration and final restoration placed. 3 months healing later. And I'm leaving the knowing where the final destination of implant treatment, that's occlusion. So you can check the top-down, the meaning of top-down in ChatGPT, March 14 version. There's a well explained about it, the top-down concept. And I published many articles with the top-down treatment planning, including the ITI treatment guidebook and also Implantology, ITI digital journal, so like this. And you can see the bottom-up method. They place the implant in advance and make a crown. You can find out this kind of bottom-up crown. And top-down, the typical top-down is root-guided implant placement. Okay, look at this. Cut the crown portion and drilling step by step. And exactly, look at this central portion of the screw opening. It's a very good placement, good working. Sometimes in the department of oral surgery, they placed implant for the implant over denture, this eyeball implants at the clothes hanger. No denture. So, optimal prosthetic strategies for multiple implants. You can find out my book here, an article here. So what is a desirable implant prosthesis for both dentist and the patient? Look at this patient. So many implants placed, and the cement retained, and the custom-made abutments, but vertical dimension decreased, not original vertical dimension. So they totally failed. So report from the local clinic to my university. So dentist and the patient desire. What is the desire? Easy retrievability and easy repair. No screw hole, no excess cement. Is it possible? Possible. And one-piece long-span prosthesis, but passive fit. This is possible because of digital workflow. CAD/CAM method, we can do that kind of fitting material. To reduce the handling time, easy insertion and removal. That kind of long span bridge, screw in 6, 8, and screw, remove the screw in every time you when you check up the patient, and minimize the screw loosening, abutment loosening, and fracture. So look at this. This is very strange situation. Oron 13 on upper, Oron 17 on lower. One-piece restorations. Too many number of implants based on bottom-up surgery. Find a bone. Oh, here's bone. Place implant. What can I do for this patient? So 10 implants on upper, 9 on lower, like this. And everything failed. Report from another dental clinics to me. So I always solve this kind of problem. So proper number and location of multiple implants based on top-down treatment planning. You can find out this book. And in 2016, I engaged in this ITI treatment guide book, volume 9. Okay, so here, fixed hybrid, the first option. The second option, fixed and implant over denture, sometimes including bar joint structure. And the third part is conventional complete denture and implant over denture. This. So, as a result, I made a decision, fixed long span restoration with implant and removable type or implant over denture and conventional lastly. So oral 4 method, and there is many kinds of direction to make a fixed restorations, fixed hybrid like that. Tomorrow I will say this kind of methodology for elderly, handicapped patient. And one unit Onlineclass restorations. There are two kinds of restorations: natural tooth looking prosthesis and also fixed hybrid prosthesis. So remember this diagram, the immediate placement after extraction and wait for 4 to 8 weeks, this type 2, and also 12 to 16 weeks waiting and type 3, and this kind of late placement after extraction, after completely resorption of alveolar ridge. But here, same patient on upper, the extraction period and the implant placement period, this we can make a natural teeth looking prosthesis, but on the lower, a little later, extraction and waiting for several months, we have to make this kind of fixed hybrid, including the artificial gum. So this kind of upper and lower fixed hybrid available nowadays without any removable type restorations. So fixed hybrid, but this patient had type 2 and type 3, so you don't need to make an artificial gingiva here. Just make it natural teeth looking prosthesis required. And like this, natural teeth looking without any artificial gum. So according to the extraction and implant placement period, we have to choose, select the proper type of final restorations. And left side is removable type patient detachable prosthesis. And right side, I hope to recommend this kind of final restoration, fixed type with the hybrid gum. So tomorrow I show the table clinic 2 times. So I will show this kind of methodology, or on 4 on lower, or on 6 for upper, like this, including the distal cantilever. Old implant, the final end position is number 6, not exceed number 6, no 7. If you make a divided restoration, segmental restorations, you can place number 7 on the lower, but 1 unit restoration, 1 connection, 1 unit, full arch restoration, and a distributed implant placement, but exceed number 6, just anterior. So like this, or on 4, or on 6. So after this treatment, I asked the patient, how about this? My life changed when I am near 90 years old with these fixed restorations. Okay, hygienic care. Removable type is better than fixed hybrid? No. If there is a food impaction here, just mouth gargling and brushing, that's all. No problem. Why? You have to make a convex tissue contact area. Okay? That's enough. Very easy to clean up by the patient or helpers. Very good. Denture, insertion, and remove is real difficult by the patient and elderly handicapped patient, and also health giver. No, it's impossible. Insertion and pull out, removable type restorations. So I recommend strongly fixed type restoration with implant for the elderly handicapped patient. Okay. Good. Thank you so much.
Thank you, Professor Leesungbok. Thank you, Professor Paek. Very interesting, very interesting presentation. I have a couple of questions for you. First of all, for Richard, we have talked about edentulism, but if you have a patient with a lot of remaining teeth, you change treatment planning, or the treatment planning is the same? And also another question, if you decide to go for an immediate loading in this patient, you prefer to prepare the prosthesis chairside, or you take an impression and send to the lab?
Okay, thanks so much. Immediate loading procedure, in case of patient who need to remove all remaining teeth on the upper and lower jaw, upper and lower immediate full dentures should first be manufactured and used immediately after extraction, okay? Not implant.
Okay.
Okay? Initially, we have to make the immediate denture. And this is because the most suitable inter-arch relationship and centric relation record and CL occlusion should be oriented for the patient comfort. The remaining teeth is very important to give it information to make a final occlusion. Okay? And when the healed soft tissue is covering the extraction socket, the type 2 and 3 just covering the healed soft tissue. Okay? And the top-down computer-guided implant surgery is carried out, and immediate loading by the implant fixed provisional is performed for the elderly people. Yes.
Okay.
So, and before surgery, I duplicated the upper and lower immediate denture. Okay, I already made before extraction, and use them to make the immediate implant fixed provisionals in the lab.
In the lab.
Yes, and immediately after surgery, the immediate provisionals are inserted into the patient oral cavity at the chair side, and occlusal adjustment is performed accurately. This is the immediate loading procedure what I mean. Okay.
Thank you for the answer.
Yes. Look at this picture, whole procedure from the immediate denture, and copy and make a computer guide template, and then one more duplicated one to make immediate restorations, okay? Immediate provisional restorations, like this.
Thank you so much. And for Professor Paek, do you think that the soft tissue contour is for the single implant immediate loading is a very important key factor to conditioning the soft tissue to have a great success rate?
Oh, yes, absolutely. In terms of the contour of the prosthesis, the provisional prosthesis, that should be concave. It should be straight from the fixture. It should have a little bit of concavity so that we can maximize the soft tissue volume. And I think the long-term prognosis of the implant is very dependent upon the thickness of the soft tissue. But if push it too hard, if you lose too much soft tissue at the beginning, then I think the long-term prognosis will be guarded. But if we can maintain our soft tissue thickness by contouring the provisional, then that absolutely will affect the survival rate of the implant.
Thank you. And for both of you, do you have any protocol, any guidelines to monitor the patient year by year, month by month? Can you suggest us something?
Okay, good question.
Thank
The checklist and follow-up, after the implant prosthesis is connected on the implant, the patient should visit the hospital at intervals of 3 months for the first year. Every 3 months, 4 times in a year.
4 times.
And for panoramic X-ray imaging and clinical direct examination. And if bone resorption of more than 1 millimeter occurs during the first year, it can be expected that additional bone resorption of more than 3 millimeters will occur over the next 2 to 3 years. In other words, it falls into the category of implant failure after 5 years. You can imagine that, okay?
Yes.
Yes. At each examination, clinically, the soft tissue around the implant should be squeezed with the 2 fingers to check the pain and whether exudate, the pus, or
Yes.
bleeding,
Yes.
okay, etc., comes out from the transmucosal area.
Yes.
If exudate comes out with the pain, do not damage the transmucosal tissue or make a dent on the subgingival part of the crown by performing a strong subgingival curettage from the outside like this. Look at this and here. But make sure to take out the crown totally and find the cause and clean, disinfect, and antibiotic ointment infusion and reconnect it. This is the most important task in regular implant inspections. After that, it's recommended to perform regular inspections once or twice in a year after the first year, okay? 4 times in a year, and then 1 or 2 times every year. And complications such as prosthetic damage or deformation caused by long-term use should be found and taken care of. That's all. That's my job.